This week on the BackTable podcast.
The plug does take a while to set down. Also, sizing the plug can be difficult because if it's a large splenic artery and you have Gen 4 plugs going up to 8 millimeters, if it's too large, you're not going to get a plug to fit. And certainly I've had a case where we, with a fellow, put in a plug. It looked okay. Took our next run and the plug was slowly chugging out to the distal splenic artery, and you're like kind of kicking yourself, going, "Oh, come on!" So you really have to oversize those plugs like crazy. Whereas coils give you a lot more flexibility.
Hello, everyone, and welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. First, a brief message from our sponsor. Today's BackTable podcast is sponsored by Boston Scientific Interventional Oncology and Embolization Division. Boston Scientific Interventional Oncology and Embolization is a global provider of medical devices. Boston Scientific's goal is to become the leading partner by enabling and developing minimally invasive procedures. Boston Scientific IOE has recently launched Embold fibered coils. These embolic coils are built on the radical idea that simpler is better. With a kinkless nitinol delivery wire, ability to deliver through microcatheters from 021 to 027, a handle-free detachment, and PET fibers providing best-in-class occlusion, Embold fibered coils give users a reliable coil option that simplifies the complex. Now, back to the episode. All right. Hello, everyone, and welcome to the BackTable podcast. Today, we've got a very special episode. We're going to discuss treatment algorithms for splenic artery embolization. We're going to talk a little bit about, mostly probably about trauma, because that's usually the most common reason why we're doing this. But also a little bit, we'll talk a little bit about hypersplenism a little bit at the end. But I'm very pleased to introduce our guest, Dr. Chris Grilli, coming from Christiana Health Interventional Radiology Group. Welcome, Chris, to the show.
Aaron, thanks so much for having me. This is a lot of fun, and I really appreciate the invite.
Yeah, and I understand you were assistant program director of the IR program there. Is that right?
Yes, assistant program director. We have the integrated pathway as well as the independent pathway, and then I have the fun duty of also being the assistant program director of the DR program at Christiana.
Well, for the IR audience, we do have some med student listeners. Could you tell us a little bit about what kinds of cases your trainees see and a little bit about the program?
Yeah, Christiana Care is based in Delaware. We have 3 hospitals in the system. We, as IRs, work mainly out of the main hospital, which is well over 1,000 beds, so it's a very big institution. It has a really large catchment area. We cover most of Delaware, as well as a large part of southern Pennsylvania, eastern Maryland, and also western New Jersey. So we do see a wide variety of cases. As far as the IR department is concerned, there's 7 attendings there, as well as on top of that, 4 neurointerventional attendings, and then 2 attendings that pretty much just do CT-guided interventions all day long. They're interventional radiologists at our institution, not body guys. And like I said, we have a very, very broad caseload. I would say we're a bit vascular heavy, arterial and venous interventions, which is really great because that's sometimes tough to find nowadays. But we also do a fair amount of oncology, UAEs, trauma. We're a level 1 trauma center, which of course we'll get into today. PAEs and all the bread and butter cases that you'd expect to see at a place like that. But we take 1 integrated resident per year and 1 independent resident per year. In the past, we had the direct pathway, which many of you may not know, but that was kind of the precursor to the integrated pathway. That's the type of resident I was. I actually trained at Christiana and then stayed on. And we've rolled that over into the integrated pathway, so we're really used to having medical students right out of medical school enroll in our program. And then we also have the integrated or independent, which is a 1-year program, and as well as ESIR in the DR section.
Yeah, thank you for sharing that. Having done residency, I did residency at Pennsylvania Hospital up in Philly, and so I got to work with, we were just talking about Dave Ball before we started, and Sam Putnam. Sam being one of your former, I know he moved on, but one of your former colleagues. And those guys definitely inspired and influenced me to go into IR, and I like keeping in touch with those guys. How long ago did Sam leave?
Oh, he left a few years ago now. He's now in Memphis, Tennessee at a OBL doing arteries all day long. But, both of them, I like to say, and this is true. I taught them really everything they know, Dave Ball and Sam Putnam. They owe me a great deal of gratitude. Yeah, that's on record, and I want that in the final podcast. I'll send that to them. But they know. But yeah, they're legends in the Philly area. It was my honor to work with Sam and to know Dave, and he's doing some great stuff down there in Memphis.
Well, let's jump into the meat of it. Splenic trauma, the topic for today. How do these patients typically present in your practice?
Yeah, like I mentioned, we are a level 1 trauma center, so this is something we do plenty of. We have a lot of interactions with the trauma team every day, spleen or otherwise. And as we know, most of these are blunt force traumas. Occasionally, we'll get a penetrating trauma, splenic injury that does go to IR, but it's definitely the very, very small minority of patients. And then when thinking about splenic injuries, you could have the acute injury. The patient comes in, they're stable, they're unstable, and they get triaged right away. And then there's also when it comes to spleens, delayed splenic rupture, which we could touch on later, where the spleen's fine initially, and then all of a sudden you're dealing with a bit of an acute situation, hours, days, sometimes even longer down the road. So we see both of those really at Christiana. Splenic embo has been going on for a long time, since the 70s when they were using autologous blood clots. So this is nothing new, but really, it took a couple decades, for IR to really get involved in the trauma algorithm. In the 90s, they were all already identifying defects in their algorithm. They were just starting to use more commonly cross-sectional imaging as opposed to just ultrasound or just lavage, and really we're seeing that if they see blush on CT scans, their fail rate for OBS alone was like near 70%. So that led the question of what do you do with these patients like this? Do you jump all the way to taking their spleens out, or are there other options? And that's kind of where IR has started to get involved, and now is well established as part of their algorithm. So when, for example, at my institution, when the trauma surgeon calls me, it's usually well siphoned out already. They're not sending me grade 1s or on the other spectrum, very, very unstable patients to evaluate. But they're usually the appropriate, we're talking about a grade 3, 4, 5 laceration using the AAST guidelines. And usually, although not all the time, those are stable patients. So I don't know, maybe we should go into because we do have some medical students probably listening.
Yeah, let's talk about the grades. Yeah, let's talk about the grades of splenic injury and kind of the treatments for each.
Yeah, so knowing these will kind of help dictate the rest of this conversation. Yeah. If we're using the AAST guidelines, we were talking about 5 grades, obviously from 0 to 5 getting worse, all the way from a grade 1, which is just a very, very small laceration. We've seen these on CTs before. You could barely see the dark laceration. On the scan, it's less than 1 centimeter. They might have a small hematoma, but it's like less than 10%, something small. And then grade 2, a little bit more of that, but still really nothing large intraparenchymal really to worry about. And then you get up to 3, where now you have either a ruptured subcapsular or a parenchymal hematoma. You have a much deeper laceration, 3 centimeters. And then grade 4 and 5, now we're starting to talk about devascularization of the spleen itself. In grade 4, more than 25% of the spleen. Grade 5, a completely shattered spleen, which is completely devascularized. So obviously a higher grade. The initial guidelines didn't even mention hematomas or devascularization, but in 2018, AAST started to notice, hey, if we see involvement of the vasculature, these patients are doing much worse, or if we see large hematomas. So in 2018, they modified it and added the hematoma sizes, added the stuff about the devascularized portions of the spleen as to better triage their patients. And even there's a world organization of emergency surgery also has a grading system, which I like even more. It's simpler, which I always prefer. It's only 4 grading classes. It kind of lumps the lower grade AAST together into a 1. And then as it gets higher, obviously more vascular involvement, but their grade 4 is just anybody who's unstable, which makes sense, right? So you could have a 1 centimeter laceration, but if the patient's unstable or not doing well, then that's not going to be the same as a patient who has a 1 centimeter laceration and is rock solid. So their grading system brings in more of the clinical side of things a little bit, which I really do like.
So how is trauma surgery deciding whether or not to send them to IR or take them to the OR? Is it based off of whether stable versus unstable?
So in the most simplest form, I always tell my residents, if it's a spleen that's unstable, those should be going to the OR. If it's a spleen that's stable, those are the ones that are considered for IR. Now that's very oversimplified. In fact, there's like a UMass study from, I think, this year or maybe last year that they were taking unstables and stables to the IR suite, and the complications and mortality were the same. So, there are exceptions to that rule. But in general, we're talking about an AAST 1, even a 2 through 5. If they're stable, you can do observation. If it's a higher grade, you take them to IR. If they're unstable, they pretty much automatically go to surgery. Now, have I done unstable patients before in IR? Sure. Let's say there's a poor operative candidate or there's some other extenuating circumstance. You just have to take each case by itself. And then if you consider, and so I said I'd mention this, PEDS patients. So PEDS patients, it's a little different algorithm. Everything kind of shifts to the left. So no matter what their grade is, you're pretty much monitoring them. You're not really, as long as they're stable. So it doesn't matter what the size of their hematoma is. Do they have a big, perisplenic subcapsular hematoma? It doesn't really matter. You watch those. And only if they start to demonstrate that they're not improving clinically, would you even consider embolization. So the criteria is even stricter for those type of patients.
Are the PEDS patients more likely to go for embolization versus surgery if they're unstable?
They're more likely to do nothing. They're more likely to observe. And it's very rare. And then if they're largely unstable, they're probably going to go to the OR. So IR's role gets crunched a little bit in the middle. Again, this is all very institutionally dependent. A lot of studies have looked at this, comparing institution versus institution, and everybody has a little bit of a different algorithm, but definitely that's the trend that's seen out there.
Okay.
But there's plenty of data in the trauma literature telling us what we need to do. They have meta-analysis with like 10,000 patients looking at grade 4 and 5s and demonstrating a much, much improved salvage rate with doing embolization versus just observation.
Okay. In the PEDS population?
In the adult population.
Oh, in the adult.
Smaller studies in the PEDS population, yeah.
Yeah. Okay. And so let's take a hypothetical from here. It's a Monday. It's, 4:00 p.m. And, the trauma surgeon runs in and says, hey, we got a grade 3 trauma, splenic trauma, splenic laceration. Can you embolize it? Can you walk through what you're doing for the audience at that point?
Oh, absolutely. Yeah. So most of these cases, we're going femoral, although I do radial as well. And, it depends on kind of what the preoperative CT looks like. But in general, we're talking about a femoral access 5 French sheath going up into the splenic artery with a primary curve, such as a C2. You could also use a reverse curve catheter. There's nothing wrong with that. I like to track it out in the case of the C2 into the splenic artery as best I can to actually get a nice picture, stabilize my access and then do a couple runs. Depending on what I see, I'm deciding whether or not to just do a distal, do a proximal, do both, maybe, and also deciding what my embolic agent is going to be. there's a lot of options out there now, which is kind of fun. We use everything from coils to gel foam to obviously amplats or plugs. There's also some Terumo plugs out there and the endovascular occlusion device. So there's a lot of really neat options, and it's a really good chance, especially for trainees, to get their hands on some different types of embolics and learn how to use them.
Yeah, just to back up 1 minute, I want to ask you, I'm sure you're reviewing the CT before they wheel them in, although I'm sure, it's always kind of a rush deal, right? They're already like at the door. But you're reviewing the CT. Do you already kind of have an idea based off of looking at that CT if you're going to embolize proximally, distally, and then what type of embolization device you're going to use, or is it kind of like you wait and see what you get when you're in there?
Yeah, I always have a plan going into the case of what I think I'm going to do. Now, how often that plan gets turned on its head the second I take my first angiogram is probably 50-50. So, often I'll have a plug pulled and waiting, to go, and then I just throw it away and we're doing something completely different. So, yeah, I do review the CT. I do try to make a plan, but, it's in intraoperatively, things change all the time.
Sure. Do you ever go radial access?
Yeah, I do radial. I would say the minority of patients I do radial, but definitely do a fair number of them. It's very nice to do, especially if they have a lot of disease or if it's a very obese patient and you don't want to go stick in the groin. It's super quick, easy to get down. A catheter of choice for that is the Sarah catheter. It tends to work great for spleens, but you could also just use a standard primary curve catheter or just an old reverse curve of any type. But the Sarah is definitely my favorite. And, it's really nice to do radial. It tends to be just as quick. You can use the same number of devices. The sheath size I use is the same. I use a 5, although I do usually use a slender, so it's a 4 French access. And those cases go really well, yeah.
And so for the straightforward celiac, and we're going to talk about challenging celiac anatomy here in a minute, but for the straightforward celiac anatomy where you get your C2 like right into that splenic, are you then putting a microcatheter through that, or do you ever embolize, even if you're able to get your C2 out pretty far, do you ever just embolize through that just because it's fast and quick?
Yeah, I do. So I would say the majority of cases go like this. I do the run through the C2. I see laceration, maybe some areas that look like some parenchymal blush, but it's not definitive. It's certainly nothing I would call extrav or anything like that. And I would say, I'm just going to do a proximal. I have the C2 in the proximal splenic and I deploy a plug or even 035 coils right through the C2. So that type of case is a very, very quick, like 10-minute case. So that's mostly straightforward. Now, let's say I see something on my first run like frank extrav or something I'm really concerned about in a specific segmental branch of the splenic. I will put a micro through that and go after that and do a distal embolization on that particular branch.
Okay.
Usually through a micro, usually using coils. Most often detachable coils because we have a bunch of them at my institution and that's what I like to use, but you can use non-detachables as well. They're distal arteries. There's no problem with that. And also in those situations, even if I do distal, I usually leave a proximal embolic on the way out. The data's mixed on this. They've looked at this, proximals versus distals, and it seems like they had similar salvage rates. There's one study out there that shows if you do both, you do have increased complications and poorer outcomes. However, I do suspect that's due to the fact that people who had both done were sicker patients. In reading the study, it looks like they didn't tease that out. So I think you just have to make a judgment call at the time as to what exactly you're going to embolize based on the data at hand.
So for, as we commonly will see, the splenic artery can be pretty tortuous. Does that also kind of help you decide what kind of embolization device to use? Let's say tortuous versus non-tortuous splenic artery.
Yeah, absolutely. I think even tortuous, I'm trying to get my parent catheter out there. However, if a few seconds of trying, it's not going or it's kicking out, because just extreme tortuosity, it's not going to go no matter what wire and catheter combo I'm using. I ditch that right away. I'll just park a reverse curve at the origin and then just go through the splenic with a microcatheter. Time is of the essence of these cases. I generally don't like to keep trying something that's not working. And then in that case, you're using coils, which is great. I mean, there's so many options out there now. There's even the penumbra pod device, which is coils that kind of act like a plug. So there's still a bunch of options out there, and certainly the cases go just as quick, and if not even quicker, because the one thing we know with the Amplatzer plug, if you use that, you have to wait for that thing to shut down, and sometimes it takes a while, and whereas coils generally go a little quicker.
So let's talk about that. Let's talk about embolization. I do want to talk about the variety of different coils out there, but let's talk about Endpoint real quick, and then we'll talk about the different, what are like the pros and cons of each embolization device. The Endpoint, what are you looking for? Is it full on stasis or just to slow it down so that you don't see that active bleeding anymore?
Yeah, the ideal endpoint, and we're going to talk about this in the context of a proximal embolization, is I see that my device has blocked flow in the main splenic artery, yet when I do the run and on the delay, I see the distal splenic artery filling via the collateralization to the spleen. Right. So that's my endpoint. I mean, shouldn't be saying this, but if I'm in a rush and I pop in a plug, I don't always wait the 10 minutes or so for that thing to go down if I'm confident it's going to go down. So I just kind of get out of dodge. However, ideally you want your final run to show that whatever device you have in there has obstructed flow in the main, and now you're getting collateralization, and maybe it's worth quickly talking about it. The collateralization to the spleen is really robust. You're getting a ton via the left gastric through the short gastrics. You're getting a lot through the epiploic, the right to the left, and then to the spleen. And then, of course, what everybody always talks about is if you do use a plug or embolic device, put it distal to the dorsal pancreatic, which will then go to the greater pancreatic and then fill up the spleen. I don't kill myself in looking for the dorsal pancreatic or where to put the plug. Honestly, even if I put the plug right over or coils right over the dorsal pancreatic, that spleen's not going anywhere because of the multiple collateral pathways out there. Although an ideal location is just right after that dorsal pancreatic branch.
Great. And so you mentioned the advantage of placing a plug, which is, kind of one and done, but that the downside, and I've seen this too, is having to sit there and wait to see that flow slow down. Whereas coils, you can pop them in, I would say just as quick, and I think it has a more immediate effect. But tell our audience your experience and kind of like the variety of different coils that you use when you're doing these.
Yeah, and that's exactly right. I mean, the plug does take a while to set down. Also, sizing the plug can be difficult because if it's a large splenic artery and you have Gen 4 plugs going up to 8 millimeters, if it's too large, you're not going to get a plug to fit. And certainly I had a case where we, with a fellow, put in a plug. It looked okay. Took our next run and the plug was slowly chugging out to the distal splenic artery, and you're like kind of kicking yourself, going, "Oh, come on!" So you really have to oversize those plugs like crazy, 20, even 40% in some situations. I like those really oversized. Whereas coils give you a lot more, flexibility. Obviously, you have much larger sizes. I do like a fiber coil if I can get it. We have all different types of coils at my institution. I tend to see them shut down quicker with fibers. But certainly the options out there now are huge. We have really, really long coils at pretty large millimeter sizes, so you can get away with 1 to 2 coils, do the case actually cheaper and quicker, and like you said, often you see the result much quicker. The trick is getting a bite, proximally, so it's nice to find a branch that you could dig the front end of the coil into, and then you're kind of good. Or if you can get a turn and get the coil to kind of grip on the turn instead of it kind of traveling out, that kind of helps with getting it in quickly.
Yeah, and you mentioned there's new ones on the market. For example, we know the sponsor of today's show is the Embold. I've yet used it. Is there any advantage to these new ones that are on the market? I know they're fibered, but there are other older coils that are fibered as well.
Yeah, the Embolds are kind of the next generation to the interlock. The interlock was great, however, was a little more difficult to form than a non-fibered coil, which was a downside. And also, it wasn't completely detachable, right? I couldn't bring it out and then pull it right back in. And certainly if the catheter sizing was off or if you didn't flush it well, sometimes they'd come detached. The Embold operates in a mechanical mechanism where, it's fully detachable. You could put the thing all the way out and pull it back in, and it doesn't really let go until you decide to break the back end of the Embold deployment device. I've used it quite a bit now. I really like that coil. I think it strikes a nice balance between having a fibered coil, which may be more difficult to form, with the fact that there's less fibers on this. The front end of it's not fibered, so it really goes in first like a non-fibered coil, like a ruby, like a bolt, something like that, where it forms very, very nicely. The fibers come later. So you get the benefit of a fibered coil, but with the deployability of a non-fibered coil. So far at my institution, I think I could speak for most of my colleagues, that's kind of been the workhorse of late of our coils. We really, really like them, and they seem to strike the nice balance.
That reminds me of like the Glide Advantage wire. You got the hydrophilic front with like the stiff back, which I love.
There's
like
another thing I
worlds.
wouldn't. I wouldn't be an IR without that. I would quit if I lost the Advantage wire. I think we used that.
I'd just walk out if they were on back order.
Right. That's it. I'm done. I'm going to find a new career. That's just one of those devices that you've come to really love over the years. And the Embolds really strikes a nice balance. And it's exactly like that.
Yeah. Peter Horner wanted me to ask you what is on your playlist when you're doing a splenic embolization, or is there no time for music?
That's an excellent question. I've evolved over the years. My go-to used to be laid back beach mix on Pandora, which brought in a lot of reggae. So it was upbeat yet kind of chill. So it kept me in a good place. I went through a Ray Charles phase for a while, also same type of vibe, and now we're just touring 90s alternative rock.
That's my
there's a little
sweet
bit
spot,
of Weezer thrown in there. Just the key is just keep it upbeat. But that's a really important question, and I do appreciate it.
He was hoping it was metal rock, but
one of my techs loves metal rock, and he'll put it on sometime. I don't know. I can't concentrate on that. I gotta get out of the room.
It's too much. I like the grunge. The 90s grunge is
90s grunge, right?
For me,
that strikes the right balance. Yeah, it keeps it going. Now, of course, if something goes wrong and I start to get pissed off, all the music goes off. It gets quiet, and everybody gets uncomfortable.
Yeah. Especially, what happens a lot of times is trauma surgeries in the window staring at every move, while you're doing the case. I would say that's like 9 times out of 10.
Oh, yeah.
The
They're there looking
room's
at you.
packed with people. Yeah.
Oh, yeah.
You have an
They're
audience
watching. Yeah. And, I have to constantly remind myself this is not the time to dance along or take a break or harass the fellow too much. But, when you have good residents and fellows, you have that option of kind of, taking a break and maybe doing a few dance numbers around the room to kind of, keep it light. So they don't tend to like that.
While you're waiting for that plug to work.
While you're waiting for that plug, you got to do something. It's either that or put in coils behind the plug and, got to save
Have you ever
money.
done that? Yeah.
No, what I do sometimes is, I hate to admit this, I'll take a little gel foam slurry and just pump a little in right behind the plug, and that gets your beautiful angiographic result without having to wait the 15 minutes.
Have you? I've had to do that too. Have you ever just done gel foam? If, for example, I guess have you ever done that, and B, why? What was the reason for just doing gel foam?
I haven't done gel foam on a whole spleen. I've done gel foam on segments. So if I saw a really ugly segment, so a distal embolization, I have done on gel foam. But then again, I am still combining that usually with a proximal coiling or plugging. So, it's never been just gel foam
by itself.
But gel foam's nice to have around.
Another question from Peter Horner. He wanted to know, would you ever consider a liquid embolic. Is there ever a case for a liquid embolic? Probably not in trauma.
People do these. Yeah, that brings us more into, other reasons to do splenic embolizations, which I don't know if you want to go into yet. But yeah, people do a lot of different things. Glue, there's obviously the coils and gel foam, but glue is definitely brought into it. People use onyx for it.
Yeah.
Haven't used it, but I could see where that may be useful. To make it cost effective, you have to find a really cheap glue to use. Glue can be quick, but if you're doing a bunch of segmentals, it tends to not be that quick. There's an onyx study just out of Jeff right down the road from me that looked at using onyx for these devascularization cases, and they found less side effects. Not sure why they had less side effects, but they did report that. So it seems like onyx is another usable option, but again, really, really pricey. Yeah, so it's something to consider. Yeah. So not for trauma. Yeah,
not for trauma. Yeah. So in a minute, I want to jump into the non-emergent splenic embolization, but real quick, as you achieve stasis and vital signs stabilize, everybody's high-fiving. Are you leaving your sheath in for when the patient goes up to the ICU, or are you pulling, and are you doing a closure device, or having somebody hold pressure? How do you handle the sheath afterwards?
Most of the time, we're pulling the sheath. Now, if the trauma team is there and they say, "Can you leave the sheath?" and we're more than happy to do that, as long as we make it clear to them that it's their job to pull now in a few days, whenever they're done with it. But most of the time, we're pulling it. The vast majority of times at Christiana, we do use a closure device just to free up the room quicker. Our problem is more room time turnover rather than cost of case. So we have a bunch of different closure devices. We have passive closure devices like the Minx grip. We also have active closure devices like the AngioSeal and the Celt more recently, which is really great for these 5 French cases, because they do have a 5 French device that the patient is pretty much sealed instantly. You just have to watch it under ultrasound. But the vast majority of time is using a closure device to close.
Okay. Yeah, that's a great point, because these are not scheduled cases. They're oftentimes brought in the middle of your day, and then everything's getting pushed back, of course. And room turnover is key, like you mentioned. So you want to get them closed up and get them on.
Yeah. Whenever I walk out of a room and say to my coordinator that we're holding pressure, I get an eye roll and a fist shaking at me. So, we got to keep things moving.
Yeah, for sure. Anything that we left out on splenic trauma before we move on to these non-emergent splenic embolization cases?
No, I think we hit all the major points.
Yeah.
Nothing striking me right away. Yeah.
Let's talk about, I don't know what's more common, hypersplenism or aneurysm. Probably aneurysms, when you say.
We do a little bit of both. Yeah. So
pick your choice.
We could start with hypersplenism.
Yeah, let's do it. So hypersplenism, I guess, let our audience know, why these patients are presenting, and in sort of like what the workup is.
So, right. There are a number of reasons why we might embolize a spleen other than trauma, hypersplenism being one of the major causes, either in a cirrhotic patient, someone with lymphoma and leukemia, somebody on chemotherapy, or somebody with a hematologic disorder. We get a lot of these consults from our cancer center and our oncologists. When I first started at Christiana, they weren't sending a lot of these, to be honest. And then, I happened to have a discussion with an oncologist just with a low platelet patient that they were not able to resume chemotherapy. And I told them about this, and they seemed shocked and amazed that this was doable, and sent us a patient, had a very robust response in their platelets, and since then we've gotten quite a few more consults for these. So this is a completely different reason than our trauma, and a completely different way we do these cases. So at the most basic level, in the hypersplenism's platelet sequestration type case, we're looking to embolize and kill off part of the spleen rather than just slow flow into it. They did look at doing proximal embos and see if it had any effect on platelets. There were a couple studies showing a little bump, but but I don't really believe them. In general, the rule is a proximal embo is not really going to have any effect on the size of the spleen or the platelet sequestration. So now we're talking about actually going into the segmental branches and taking out flow to certain portions of the spleen. And the classic teaching is, well, you take out about 40 to 70% of the spleen, and that will give you a safe bump in your platelets, a reliable bump in your platelets, and even in your white blood cell count a little bit as well, without having a ton of complications or not having very high complications. Because this procedure is actually a pretty morbid procedure, and I don't think people appreciate how dangerous this procedure can be. So certainly when I get a consult for the oncologist, I want to see that patient in my IR clinic before I schedule them for the case, because they need to know. The oncologist isn't telling them. They're telling they're going to do a non-invasive procedure. It's going to be fine. Your platelets are going to bump up, and then we're going to resume chemotherapy. But I need to talk to them seriously about the morbidity and the mortality, even with this procedure in the office. Also explain to them that, hey, it's not going to be a smooth road. You'll probably be in the hospital a few days after the procedure. You might be in a lot of pain, even though I'm going to give you a ton of pain medications. You're going to be nauseous. You're going to have this post-embolization syndrome. And even after you get discharged, you're going to feel pretty beat up for a little bit. So it's not a procedure to be taken lightly, as some of the referrers seem to think of it.
So when you're doing you said about 40%, right, is the target percentage roughly?
40 to 70, depending on what you read. Yeah.
Yeah. So you're in the middle of your procedure. How do you determine percentage? Do you use cone beam CT and you're looking for, and then you do like an injection and looking for, kind of roughly calculating that percentage based off of enhancement? How do you determine that?
I would say the majority of the time I'm not using cone beam CT. However, it is definitely a good thing to use. I just tend to be impatient and want to get out of the room as fast as possible. A lot of people do use cone beam CT to really get an accurate depiction of how much spleen you're actually taking out. I'm doing runs, and trying, and sometimes different obliquities because you can get tripped out on a single view, and trying to estimate based on the runs how much of the spleen roughly I'm taking out. I know it's not dead on accurate, and I have used cone beam in the past, but it gives me a general idea. There's actually a really crazy study out of Japan where they actually looked into this and they measured the feeding artery and were able to accurately predict how much of the spleen they were devascularizing from taking out that feeding artery. That would be pretty cool to do, although you'd have to start measuring every artery and, doing calculations along the side. So although it's neat, I don't see a ton of people doing that. But the risk is you can go from, and certainly I've been in this situation where I was at 40% and I'm like, I want a little more, so I'll take one, and boom, you're at 80% the next embolization. So it can go from too little to too much very quickly. So you got to be careful with that.
Sounds like maybe a neat AI project if somebody could
it'd be totally
an
cool.
algorithm, Yeah. I don't know if there's really product market fit there, or like the need for it, but I mean, there's definitely a product market fit, but I don't know if they're like what the number of hypersplenism cases being done in the United States on a yearly basis.
Probably be a little low. But just
eventually,
like
stuff like that could be applied. Yeah.
Oh my gosh, totally. You could do a run. It can map out the arteries. Do a spin once in the beginning, and then kind of estimate based on what you've taken out. I could see that happening. How much spleen you're taking out per branch. But that'll be down the road. But, just like in trauma, there's also a different number of devices we could use for this. We touched on this already, going from gel foam. You could use coils. You could use glue. You could use particles, which is probably the most common. I've used quite a few different things. I have used particles, 300 to 500 most often, and then sometimes 500 to 700 if we're talking a range micron. For the branch, and that goes very well. I think it's quick. I've also used a lot of coils. I really like using coils for this. It gives me very, very precise control. I can get into specific branches, and I can even do tiger striping, where I do a branch, I skip a branch, I do a branch, so that you don't have one large area of necrosis, because certainly the big fear is, abscess and sepsis after this, peritonitis and all the things that go with that. So theory is you don't create one large necrotic area, potentially you're gonna get around that potential adverse event. So coils are also very, very good for this, and they've done studies looking at this. Again, a lot of this is in the Japanese Asian literature, but they've looked at coils versus gel foam and found that the complications were the same, and the platelet reduction, or not reduction, increase was also the same. So it really leaves a lot of options for the IR to decide what they want to use.
Yeah. And so we got a few minutes left here to just briefly talk about the aneurysms, which I would imagine you'd only really use coils. I mean, you can't really use plugs. You can't really use really coils would be the only thing you would use for aneurysms. How often are you guys treating those in your practice?
We get a few of those a year. For whatever reason in our practice, we get a lot more hypersplenism than we do aneurysms, but we do see a fair number of aneurysms. And you're exactly right. We're using coils to do those, generally long packing coils. The longer the better, depending on the aneurysm size. We have also used covered stents, in cases where there's, where we tried to maintain flow to the spleen, and just to try something different, to be honest. Use a covered stent to cover it up, especially if there's a short neck and you feel like you can't seat a bunch of coils on the inside. Also, another thing we've used is just coil distal, coil proximal, and don't coil the sac itself, because as we've discussed already, depending on where the aneurysm is, you're not going to kill the spleen by just coiling that small segment out. There's going to be robust collateral flow, so you're good where you don't even have to pack the aneurysm sac. So there's plenty of options when it comes to aneurysms, and they can be a lot of fun to do. My favorite is just packing the sac, though, because it's fun to do, and it's cool to do.
Yeah, and so I guess what I've seen people do, like put a framing coil in there, and then just like pack it with fillers after that, for the most part. But all detachables, right?
Detachables.
You got to keep. Yeah.
Oh yeah. Yeah.
Have you ever had an issue where like a little end of a coil sticks out, and you got to decide what to do? Do you try and snare it, or just leave it as is, because it's the spleen? It's not really going to shut down flow to the spleen. What do you do in those kinds of scenarios?
Oh, sure. That happens all the time. That's another thing you can see with GDAs and stuff like that, where you just have a little tail sticking up, and you're, it's always on the last coil. You're always like, I think I'm done, but I'm going to put one more in, and then that.
Totally.
So it's always that one. When talking about the spleen, it's not a big deal. I would just leave it. Honest to God, even if a whole coil kind of flicked off and fell into a segmental branch, you're not gonna really worry about that. Right. You're gonna cause more damage, more radiation, more time mucking around and trying to get the thing out. So you have to, although it doesn't look pretty on your run or on your pictures, you have to, kind of put it all into perspective when deciding how to chase things like that.
Yeah, splenic artery embolizations don't always look pretty anyway, I mean, in a trauma case, other than a plug, it's like...
Exactly. They look like a mess no matter what. Yeah.
Yeah, exactly, yeah. I think that pretty much covers it. Anything else that we left behind, Chris, that would be useful to the audience when it comes to splenic artery embolization?
No, I don't think so. Just, I mentioned they're going to be hospitalized for a couple days. I do put these patients on PCAs often, with or without a steroid bolster, and then Toradol is also very useful to use, and and sometimes I get this question often from the patient: do I need vaccinations? The data suggests you don't, because you still do have remaining splenoparenchyma, which will eventually start to hypertrophy as well, which is sometimes why you need to do repeat procedures. So you don't need to be vaccinated as long as you're leaving some spleen behind, which is a common question. But I think that covers it.
Well, Chris, thank you so much for coming on. We really appreciate it. To our audience, if you have any questions or want to look up any of the resources that we mentioned, for example, the grading scale from 2018 AAST, we'll put those in the show notes so that you can have them ready and handy. And thanks everybody for listening. Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritts, and co-hosts
Chris Beck, Sabine Dond,
Michael Barraza,
and Ali Behetti.
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson,
Josh McWhirter,
and Ness Smith-Savadoff.
Design and Digital Marketing led by Brian Schmitz.
article and transcript support by Taylor Robinson,
and Delaney Aguilar.
Social media and PR by Ann Dang.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening, and see you next week.